Hi everyone, my name is Jeff Liao. I'm a physician at National Hospital, and today I'll be discussing discharging COVID-19 patient from the hospital. I do not have relevant financial disclosure, and this presentation is purely for educational purpose. We'll be going through a framework for assessing discharge readiness, and we'll also bring up some of the public health challenges and post-discharge issues we need to consider. We'll continue to use the example of a 30-year-old male Spanish-speaking patient with no non-past medical history and about 5 days of progressive symptoms. And some of the summaries so far are he's tested positive for COVID-19, has elevated inflammatory markers, lymphopenia, chest CT with the typical bilateral ground glass opacities, and O2 sat about 89% on room air. On day 3, he started to feel better and he asked you if he's ready to be discharged home, even though he still required about 2 liter nasal cannula to maintain his resting sat about 90%. Right now, we do not have a definitive criteria for discharge to assess the readiness for discharge, but we have a set of tools we can utilize, and I'll be walking through all the bullet points, including timing, respiratory symptoms, laboratory data, imaging findings, and isolation precautions. Timing is quite important to consider because the patient can still deteriorate about 1 week since the initial onset of symptoms. In our case, our patient is outside that window, but he's still within the window for development of ARDS, which is between 8 to 12 days. Luckily, he's quite young and do not have comorbidities that may offset his odds. Hypoxemia is quite common for COVID-19 patients in the hospital, and they may still require oxygen at time of discharge. We have to make sure that they're stable or at least have improving parameters prior to discharge. A cutoff of 90% can be useful because it offers about 84% sensitivity and 97% specificity for prediction of survival. Dyspnea can also be a symptom that we use to gauge the risk and benefit prior to discharge. In the United States, CMS has waived the requirement for in-person testing, and that really helps to facilitate the discharge process because we no longer need to ask nurse for ambulatory saturation or ask physical therapists to document their O2 saturation activities, but they still need to be monitored closely for decompensation. One way to monitor may be using a home pulse oximeter. This is quite controversial still because in our studies we found mixed reliabilities with this tool. We may consider using the right middle finger and the right thumb because that offers the most reliability. It's important to still discuss symptoms that may become concerning, including dyspnea, chest pressure, confusion, and discoloration of your skin tones. Some of the labs we use on mission may still be useful to monitor disease progression, including white count, liver enzymes, CRP, ferritin levels. D-dimer lymphopenia may be useful because it's found to be correlated with mortalities. And for the most critically ill patients, they usually have uptrending inflammatory markers or procalcitonin levels. Imaging finding may be variable on presentation because up to half of the patient may not have chest CT findings on presentation. Chest X-ray findings, that's typical, including bilateral infiltrates. In chest CT findings, we may see ground glass opacity, such as in our example. It's important to remember, like Debbie has discussed, that those findings are non-specific and may overlap with bacterial pneumonia or heart failure patients. One thing that's important to consider for public health reasons are removal for precautions or isolation. It's important to know that right now, before discharge, they do not need to have resolution of their precaution. A test-based strategy that we utilize are looking at their fever trend to make sure that they are febrile for at least 24 hours in absence of antipyretic, have some improvement of symptoms, and these 2 negative COVID-19 PCRs at time of discharge. One thing to remember is that up to 95% of patients are no longer infectious around day 15 of presentations, and no patients are found to be infectious beyond 20 days. And because of this reason, that This process can take quite long. CDC is recommending using symptom-based strategy for discontinuation. We have two categories to consider. One's mild to moderate, which encompass patient that has at least 10 days since the onset of initial symptoms and 24 hours since the last fever. For the critically ill patient, we're talking about at least 10 to 20 days since initial onset of symptoms and 24 hours since last fever. Those patients may be immunocompromised or they may have history of transplant, so it may be helpful to obtain the ID counsel in those cases. It's important to remind our patients on discharge to continue to take safety precautions, including washing hands, stay at least 6 feet away from others, and wear a mask. We're not entirely sure regarding the reinfection risk for COVID-19 patients. Some patients may still have virus shedding up to 3 months since the initial diagnosis and still have positive results. We do not have FDA-approved post-exposure prophylaxis for families or roommates exposed to COVID-19, but that may change in the future. For some public health considerations, it's important to follow your local news and know guidelines from the public or state health departments regarding the latest updates. For our patients, it's important to know the outpatient environment on the support or the support system he may receive at time of discharge to make sure that he's has a stable environment for him to. And most importantly, it's important to ensure that we have everything that we need at time of discharge, include making sure oxygens, medications are delivered to the patient's bedsides, and that we have appropriate outpatient follow-up. One thing that's easy to do maybe to have a post-discharge phone call set up within 1 to 2 days of discharge. In the future, we may also need to consider vaccination once that becomes available. And I'm happy to have the chance to talk with you about the discharge process today, and I hope you learned something. Thank you.